much waiting on you now.
Yeah, and I'm pretty much trying to get this thing started.
Gotcha.
Yeah. I don't know why it's not letting me start the meeting. And it's worked the other day. I even tested it.
It's usually how it works. I've tested a few things that haven't worked out so far this last day or two.
All right, give me 1 second. Let me get logged back in, I think. I'll try to fire it back up in just a moment and see if that does anything different for me.
Still there, Connor? All right, anyone that's listening to us on the YouTube, we're trying to do something a bit unique here and actually stream to you a presentation streamed to us from Salina, Kansas. The COVID thing has one of our speakers kind of locked into where he is, but he wanted to help, so we said we would try this. So we may have to reset his Zoom video, so we may have to.
All right, I think we're going now. Are you, how's it looking on the YouTube?
YouTube's going to be a bit behind us. All I see is you to join without video.
Okay.
Yeah, come on here.
Yeah, because from my end, it's showing up, I think.
Okay. Oh, my bad. Totally gone. Walkers. Still there, Connor?
Yep, I'm still here.
Actually,
yeah, there's a lot of names popping up in that YouTube chat that I've not seen in a while.
Oh, you watching that too?
Yeah. So it should be sharing the screen now. It should be.
None of my buttons on my end are working. Can't do join without video or join with video. I'm afraid to do this, but I almost have to call you back.
Hang on 1 second. Let's do.
I keep seeing flashes of your screen.
Okay. What I may have to do then is actually stop your video and see if that changes things. Like you said, it's a couple minutes behind the everything, so. Okay. So on your end, are you seeing my screen?
Nope, just myself.
Okay.
I have a window that's video preview, join without, join with, and nothing works.
Okay.
You see YouTube?
I do. I can't see really anything.
Yeah, not a whole lot there, but my figure out one thing. What do you think, Connor?
Well, let's see. It's not. Did we push the actual Zoom link out to people, didn't we?
I did not.
Okay. Do you have an easy way to forward that email to the people that are wanting to participate today?
Sort of, but there's like 80 of them.
Oh, geez. Okay.
Can I?
You know, let's do this. Okay, 1 second.
The only solution I have right now is to restart the call.
Sorry, let's try that link there. Maybe. I don't know if people were able to try to join actual Zoom or not.
Still there, Connor?
Yeah, so here.
Okay. I can't do anything on my end, so I don't know what you're trying to do on your end.
Okay. I pushed out that Zoom meeting link there in the chat. I don't know. Why don't you try to disconnect and come back in? We'll see if that works.
All right. All right. Connor, are you there? Connor, you there? Oop. All right, Connor, we got you.
Yeah, I hear you.
We see your screen. Should be good.
Hey, excellent.
Yep.
All right.
Calling you back, basically.
I'm gonna go ahead and mute you.
Okay, that's fine.
Simply because I'm getting some audio.
Sure.
All right, well, good morning, everyone. Sorry again for the kind of technical glitches that we had going on there today. But we'll get started. Today we're going to cover a couple different topics. We're going to start off with infectious disease and sepsis, and then we'll move into a capnography lecture. So, for those of you who don't know me, my name is Connor Bounds. I am a field paramedic with Reno County EMS in Hutchinson, Kansas. Completed my Master's of Science in Biomedical Sciences from KCU in 2015. I was a field paramedic in Wichita, Kansas for a while, and many of you know me as a brand spanking new EMT at Newton County back in the day. So yeah, I'm glad to be back here. Grateful very much for the opportunity that Jeff has given me to come back and do this again. As you guys have seen already, we do have had some technical glitches this morning, so I'm hoping that that will be the last of those. But you know, like a lot of people in EMS, we found a problem and we powered through it till we overcame it. Just so you guys know, there will be a couple of interactive learning activities in this whole thing. So if you look down here, if you could text the following to the number 22333, you're going to send to that number the phrase driven mouse 532. Again, that's 22333. You're going to send driven mouse 532 to that. All right, so we're going to get started with this infectious disease and sepsis presentation. So when you guys get kind of logged in, we'll take a look at this. But which of the following saw the greatest increase in diagnosis between 2006 and 2014 in EDs in the United States? Was it an influenza diagnosis, a sepsis diagnosis, lung disease of all types, or the dreaded geriatric hip fracture? And let me toss in that stuff there to you real quick in the chat as well. All right, so we're waiting here on our diagnoses. It should be live right now for you guys to start participating. And immediately after you type that stuff in, you should get like an auto reply, and then you can send in the information. Well, there we go. Okay, so A, B, C, D, or E is what we're looking for. Or, sorry, A, B, C, D. There's no E there. And you know what? If this doesn't work either, then we will we'll move
I guess. Okay, all right, getting a couple of responses there. It's active, and I am not sure why it is not showing up here in the presentation. It's supposed to. Like I said, you know, technical issues, and they're always fun, and we might have to take a look at this between next presentation. Okay, I've got 5 responses here, but for some unknown reason, they are not showing up on the screen. So as of right now, we have leading the way flu at 60% and sepsis at 40%. Correct answer is actually sepsis, and we'll get down into the numbers of that in a little bit, and we'll kind of circle back to sepsis later on in the presentation as well. So the pathophys of resistant infections. This is our old friend staph. It's around everywhere. It's in our nose. It's on our skin. It is the thing that is responsible, as you all know, for MRSA. Yeah, specifically Staph aureus right here. Yeah. So penicillin against staph came out in 1941. We found some mold growing on some bread, and we decided, let's throw this at some staph and see if it kills it. And you know what? It's great. It did. For a while, the penicillin against the staph worked. And by for a while, I mean less than a year. So within, you know, less than 12 months, the penicillin had adopted strategies to fight off the penicillin and continue to survive. Methicillin, okay, same family, came out in 1960. Staph didn't even wait a whole year. It said, oh, hey, this is kind of similar to the penicillin that I've been fighting off for, 18 years. Let's just go ahead and make ourselves resistant to it too. And so, yeah, MRSA has actually been around since 1960. We're still continuing to fight that today. So there are 4 main ways that a bacteria will actually produce resistance against an antimicrobial. So against your antibiotics, it will do 4 things. Number 1 is it will produce what is called an efflux pump. And what happens with that is it's actually a pore or a protein in the cell wall that when that drug comes in, it actively pumps that drug back out of the cell and goes, no dice, you're not getting in here. The second way is to limit the uptake of the drug. So, for instance, you've got your staph, you hit it with some penicillin, and the penicillin molecule is going up there to the staph bug, and it goes, oh, there's no place actually for me to enter. So I'm just not going to be able to get into the cell. A lot of times that happens down here with the modification of the drug target. So it will either not have a receptor for that antibiotic, or it will, inside the cell, actually change the target where that drug is supposed to go. So it will change the proteins and stuff that drug is going against, and will stop it from working. And the final mechanism is actually the inactivation of the drug. So here what we have is a couple little vesicles inside our staph bacteria, and when that penicillin comes in, those little bodies release some kind of molecule, usually another enzyme that goes in and will inactivate that drug. So those are the 4 main ways that it basically tries to survive. Influenza. Yes, we are headed into influenza season with a vengeance. I hope everybody here has gotten their vaccine. If not, it's not too late. Get in there, take care of it, get it done, please. Heaven knows that most EMS agencies across the country don't have the staff right now to deal with both COVID and people with influenza. So make sure you get that shot. So we have four main influenza types. And types A and B are those that cause our normal seasonal flu. Those are the ones that, knock people down on the rear end and will, hospitalize some, keep people out of work for a few days, that kind of stuff. Influenza C, it's primarily a mild illness causing influenza for people. And then influenza D is our cattle-borne influenza. So when we start talking about subtypes of the flu, we talk about our H1 and our N1 or H7N2. What are we talking about here? Well, the H's and N's are the way that we can classify the actual structure of the influenza. So H is hemagglutinin and N is neuraminidase. Those are two cell wall bound proteins that actually stick out from the influenza virus, and we use those proteins to classify things. So we have 18 H's and 11 N's. So for example, our swine flu pandemic of 2009 and the great influenza pandemic of 1918, that was our H1N1. Obviously, we had been dealing with H1N1 for almost 100 years. There is a good book called The Great Influenza, written in about 2007, 2008, that actually outlines how we got to, battle H1N1. There's a lot of thought that it actually started up the road from my house at Fort Riley, Kansas, with guys coming back from combat in World War I. And kind of an interesting caveat, the great influenza pandemic of 1918 actually started pushing people toward making medical school more competitive because they realized that we needed a real, science-based education and not just, hey, let Joe Schmo follow around the county doctor for a couple years and then give him a degree. But anyway, that's another thing. So here's a little dad joke for you guys. I know that most of you would not expect me to come in and not have a couple of those. So what is the difference between swine flu and bird flu? Well, swine flu needs an ointment and the bird flu needs treatment. Wah, wah, wah. That's really why I didn't want to come down and give the presentation, in person. It's because I wanted to tell this joke and not have to worry about flying vegetables. So when we're talking about flu, let's look at our seasonal flu deaths. And these are the last couple years that we have the information for, 2017 and 2018. They're still compiling a lot of our 2019 data. So in 2017, we had a bad year. We really did. The total flu deaths for flu in 2017 were over 60,000 people. It was almost close to 65,000 people. That was unfortunately one of the years that we got our influenza vaccine wrong. We'll talk a little bit more later about the production of the vaccine, how we get what we put in there, but it was a pretty abysmal, something like 18% effectiveness on that year. 2018, we did a little bit better, and our deaths were in about the 35,000 range. Still sad. We don't want to see anything like that, but obviously almost half of what we were in the 2017 influenza season. You can look over here kind of on the far end of the graphs. This is sad. We don't want to see our young people die from influenza, but obviously as you increase in age, specifically with these 65-year-old individuals, that's where a lot of our deaths come from. So even if your grandparents can't get the influenza vaccine, you guys need to get it so that you can protect us, protect other people. Herd immunity, that's the word of 2019 and 2020. So another question for you guys. Influenza is actually most contagious in days what through what of the disease course? Days 1 through 2, days 3 through 4, or days 5 through 6? Go ahead and go activate that for you guys so you can get in there. So we're talking about the influenza disease course. You are most likely to pass it to other people in what days? So our options are option A, 1 to 2, option B, 3 to 4, or option C, days 5 through 6. Okay, all right, awesome. I'm seeing some numbers coming along in here. Grateful for that. Let's see. All right, so 3 to 4 is what I'm seeing both in the YouTube chat and on the other thing. So, all right, you guys are correct. It is in fact days 3 through 4. That is our most contagious period. So this right here is our normal progression of influenza. The day that we are infected is day 0. Usually about 48 hours later, we begin displaying our symptoms. And then days 3 through 4, please keep your happy little rear end at home because you're just going to be shedding viral particles all over the place. Like I said, this is the normal progression of the influenza. There are some abnormal cases out there. Some people may actually be contagious at day 1. Those are kind of few and far between, but it's out there. Everybody's a little different when it comes to some, things as far as disease process. But by and large, days 3 and 4. Some people can actually continue to be contagious up until day 7, which, yikes, I would hate to think about walking around for 7 days just doing this to people. Oh, that's gross. Coughing, sneezing, all that fun stuff. For the love of Pete, sneeze into your elbow and then hand sanitize your elbow or something. I don't care. Just don't cough on people and sneeze. So, influenza is primarily transmitted via droplets from coughing, sneezing, anything that forcefully expels air out of our lungs. So, influenza is primarily a droplet precaution disease. We need to stay 6 feet away from people who are coughing and sneezing. Boy, that kind of sounds familiar, doesn't it? Here we are smack dab in the middle of COVID-19 or COVID 2022, or I don't know, however long this is going to go on for. But by and large, droplet precautions. If you have to be within 6 feet, for more than a few minutes, then you need to wear a mask and eye protection, that fun stuff, so that you're not catching it when the person in the back of your truck sneezes into your eyeball. Which, the parents in the room know that that happens. Never really, even in EMS, had I had to worry about someone sneezing into my eyeball until I was a dad. But it is what it is. Now, it is also possible to transmit the influenza vaccine or the influenza virus, flu virus, through touching an object, and then if you touch your eyes and your face. So those people who cough into their hands, and then they go and touch the doorknob at at the hospital or whatever, and then you come along in the middle of a busy shift, you're like, I got to use the bathroom, and you run in and you touch that doorknob, and oh great, hopefully you've washed your hands and haven't touched your face in between touching the doorknob and going to the bathroom. So for our influenza transmission and our signs and symptoms for the adult, there are 3 major things that we look for when it comes to how we're feeling and kind of going down the flu pathway. And those are muscle or body aches, so your myalgias, your arthralgias. Everybody here's had the flu. It hurts. It hurts to breathe. It hurts to, turn your head to try to get a better view of the TV. Everything just hurts. Headache is also common. So like I said, everything from up here down to your big toe hurts. And then fatigue. Your body is just bringing your whole immune system to bear on this virus, and you are just exhausted. Now, when we talk about fever up here being a symptom, we're talking about true fever. We're talking about the medical definition of a temperature equal to or greater than 100.4. You may have people who have headache and fatigue, and they tell you, "I've had a fever." Okay, did you take your temperature? Oh yeah. It was 99.8, but I always run low, so that's a fever for me. No, they do not have a fever. You can kind of start pushing, uh, your flu a little bit further down your list of differentials on those patients. Now, this vomiting and diarrhea, that is actually a sign and symptom that is commonly seen in our kiddos. So for the adults, they've just got the achy, tired feeling all over, and then the kiddos can have all the aches and pains and fatigue with them. They also have vomiting and diarrhea. So watch them because they're relying upon us for food and drink and whatnot. So we need to make sure that we're taking care of them by keeping their fluid status up. So when we're talking about the diseases, and we see these big old long names, we've already talked about the H's and N's. This is how we actually classify our viruses. So the type there is which type is it? A, B, C, D. The name of the city is where it was first isolated. The strain here, this number here is the strain that is out of all of those. What is the, was it the first strain isolated, the second strain isolated? Because these things mutate all the time. You'll have multiple strains throughout the year. And then that last number is the year isolated and the subtype. So influenza A, Sydney 597, it's type A. They isolated it in Sydney. It was the fifth one isolated. They found it in 1997. Its hemagglutinin is type 3. That's the spike on the virus particle, and its neuraminidase protein is the second type also there on that virus. So when we're talking about deaths and transmission of bacteria now, these are our kind of our nosocomial infections, the things that we get in the hospital. How big of a problem is this? You can see up here, there's actually a website. It is called the CDC Emerging Threats website. And this is actually a pretty cool database to dive down into. And you can look and see what kind of bacteria are popping up. Where are the hotspots? What are we looking at? What specific types of bacteria are becoming an issue for us? And they also outline, treatment plans and current guidelines for different things. So in 2017, we had over 12,000 C. diff deaths in the United States. We talked about MRSA earlier and how, we came out with our methicillin in 1960, and by the end of 1960, staff was like, "Haha, I'm not going after you anymore." So, C. diff, that's one of our big ones. We've all transported that C. diff patient with just that awful runny diarrhea. It's once you smell C. diff for the first time, you're never going to forget that smell. Next, we have a big issue still with MRSA and VRE. These are the three heavy hitters. It's out there. It's community acquired. We get it from other people sometimes, but man, these are the ones that we have to watch out for, especially in the hospital and pre-hospital setting. Decontaminating your equipment and stuff. Talk about that a little bit too. So, you can see here when we break it down on a pie graph, C. diff is responsible for 42% of the deaths out of these four bacteria in 2017. MRSA was almost 35%. So it's out there. It's dangerous. It's not good. So we talked earlier about how big is the problem. Sepsis was the largest increase in ED admitting diagnoses from 2006 to 2014. Well, how much did it increase, though? That's kind of something that we need to look at. Sepsis, except for those individuals who are in labor, we went in 2006 from about 540,000 diagnoses to 1.4 million. That is an increase of 161.3%. It is crazy. Sepsis is a huge problem. In the United States, it costs us almost $20 billion a year to treat sepsis. JAMA, the Journal of the American Medical Association, released a study in 2014 saying that sepsis contributes to 1/3 of in-hospital deaths in the United States annually. So sepsis is a huge deal. Now, we've understood a little bit about sepsis for about 2,700 years. The poet Homer actually first described it almost three millennia ago as a rotting or a decaying of the human body. And like I said, it's the largest cause. It is the largest cause of in-hospital morbidity and mortality in the U.S. So they may not die from it. The mortality may just be 1/3%, or sorry, 1/3 in the United States. But it also contributes to morbidity. So those people who get admitted with sepsis, they may have long-term sequelae with their disease process. They may come out with paralysis or any manner of different things. So they're not dead, but they've definitely got some morbidity. They've got some issues going on with it. It's actually, as far as deaths in the United States, sepsis causes between 15 and 30% of all ICU deaths in the United States annually. So, yeah. So we've talked about the background. We know it's a huge problem, okay? We know that when they get to the hospital, if they're already infected with something, they have a terrible risk of having a poor outcome. We know that when they're there, even if they don't have sepsis, there's a chance that they're going to catch something while we're there. How do we, as pre-hospital providers, step in and go, we can help start slowing this disease process. We are going to actually even prevent the patient from coming down with a sepsis-causing agent to begin with. You guys are all familiar with this. The wonderful parts of the EMS symbol. Truth be told, I think this was on a test in paramedic school, and I promptly forgot it after the test. So we're going to cover it today as much for my benefit as your guys. So one of the first things that we do, there's 6 steps to it. We have our early detection, our early reporting, our early response, early on-scene care, care in transit, and the transfer to definitive care. Early detection. This is where we step in and say, hey, what populations in our area have certain risk factors for certain diseases? You can get this by actually going to the health department. They're required to maintain records of the community spread of tuberculosis, HIV, Hep C, flu, MRSA, other drug-resistant organisms, and then any other organisms that the CDC lists kind of annually. So those will rotate. For us as providers, we want to not get infected with things either. And so we have to think about infectious diseases and sharp exposures. So failure to use the appropriate equipment. Make sure you have a sharp container on your truck. Don't leave your needles lying around. That leaves you at risk. That's a risk factor for a needle stick and contracting Hep C, HIV, any of those other bloodborne pathogens. We also have the potential of exposure to infectious fluids and tissues. So like I talked about earlier, when your kid has the flu and they coughs in your eyeball, I mean, your patients can do that too. Potential tuberculosis patients, slap an N95 on them, wear an N95 yourself. But you need to be, understanding that you have the possibility to be exposed to infectious fluids, tissues, and patients with infectious diseases. We also have to think about our high-risk procedures. Look at COVID. I don't know what you all are doing down there, but we've essentially stopped our endotracheal intubation. If we have a patient that needs an airway, like in a cardiac arrest, we will drop an LMA We will still do tubes for like RSI and stuff like that, but we're very cautious. We do the full PPE, gowns, gloves, face masks or face shields, N95, all that stuff. We also have to consider, as EMS providers, poor hand washing techniques. If you can, make sure you wash your hands between calls. But if you're going to get someplace, you don't have the opportunity to get to a sink, then alcohol, the hand sanitizer, the paper cut finder, as I like to call it. We also have to think about cleaning our things, and we're gonna delineate here between cleaning and disinfection. So cleaning is the process of actually scrubbing to physically remove the germs or whatever infectious agent is on there. And disinfection is where we use water and detergents and scrubbing to actually kill using the detergents and then remove using scrubbing the germs that are there. And you need to think about your different things that you touch. Your radios, both your portables and your truck mounted radios. Anything that comes in contact with the patient, please clean your thermometers after you take care of your patients. Clean your stethoscope. How many times during a shift do you clean your stethoscope? Don't do your blood pressure in the house and throw your stethoscope and blood pressure cuff right back into the bag without cleaning it. Just leave it draped over the top and clean it when you're done. Door handles, all your stretcher controls, all that fun stuff. So remember, the big thing is clean first and then disinfect next. You need to think about what you're using to clean things. There are what is known as a contact time for your disinfection agents, and those are the amount of time that that cleaner has to stay on the surface in order for it to work and do what it's supposed to. So here's some recommended ambulance cleaning and disinfection products here. We're going to take, for example, looking at bleach. So hey, this is great. Look, bleach, a 1 to 10 dilution, C. diff, it'll take care of it, but it's also deactivated by organic material. So look here, surface must be cleaned prior to use of the bleach. So if your patient has C. diff and they have had an issue of explosive diarrhea in the rear of your truck, then any fecal material that's lying around on that bench seat or the floor, if you don't actually physically scrub that out first and then apply the bleach, you've done nothing. You've done absolutely nothing. I mean, I would like to think that we wouldn't leave poop on the floor of our ambulance, but I mean, you can't see it all the time. So it's important to actually do a physical scrubbing and then use the disinfection agent after that. So the next part of our Star of Life here is early reporting. We need to pass on the potential of an infection or possible sepsis when we do our phone or radio report. So call your sepsis alert if you meet the criteria, again, which we will discuss in a moment. And then also you can relay your concern for a possible infectious disease process. Even if the patient hasn't met the criteria for a sepsis alert, you can still say, hey, I feel as though this patient may possibly have an infection going on right now. Early response, on-scene care, and care in transit, that is all PPE. You need to be wearing the appropriate PPE for your patient. We all think back to our pre-COVID days, and nobody really ever wore a mask unless we thought, our patient had TB. I can still remember the first time that I ever put a mask on a patient and myself. I was working with Lee Flory one night, and we had a suspected TB patient, and it was like, oh, okay, it's time to put on all of our gear. Let's do this. So yeah, wear the proper PE for the proper situation. You can find all that information usually in the CDC website, or if not, your organization or your local hospital should have a good infection control person that you can talk to about that. And then finally, we have our transfer to definitive care. This is where we go and we give our proper handoff report. We may have called in our radio report and given that to somebody, but you know what? chances are you're not going to have the person, especially in larger municipalities, the person who is giving your or taking your radio traffic, they're not going to be the ones taking care of the patient. For example, in Wichita, there's a dispatcher at the hospital, or at one of the hospital systems. They're an EMT or a paramedic usually, but they don't see the patient. They just take the report, put it into the computer, and so you need to pass on your information when you're giving your handoff report as well. So here's another one for you. To what mean arterial pressure should the systolic blood pressure be titrated to with Levophed in septic shock patients? So this is our little untitled word cloud here, and we will go ahead and throw this up for you guys so that you can take care of it. So, to what map should the systolic blood pressure be titrated with Levophed in the patient suffering from septic shock? Always a good time for coffee. This is my dad fuel. Okay, so I'm starting to get some answers in here. Looks like we've got a systolic pressure of 100 is one of our answers. 65, 60. All right. So the answer is actually 65, and we'll give you the formula for calculating that here in a little bit as well. So what is sepsis? All right. Our body has a natural balance between inflammation and anti-inflammatory processes. So think about when you take your Motrin, your ibuprofen, when you've got a swollen knee. Okay, you've got some kind of inflammatory process going on there. You know that you're hurting. Hey, we're going to take an ibuprofen, knock down the knock down the inflammation. So what we have here is kind of a teeter-totter between the pro-inflammatory molecules and the anti-inflammatory molecules in our body. So when this teeter-totter gets out of balance, and specifically when we start moving more toward the pro-inflammatory side, that's where we start to have problems with blood pressure, tissue perfusion, things like that. Now, there are many byproducts of bacterial infection that will produce things like dilation of the blood vessels, activation of blood clotting cascades, movement of your white blood cells and things to the site of infection. All that will start to cause, your inflammation in the body. So we have three basic definitions or levels, if you will, of sepsis. So we have our sepsis, our severe sepsis, and septic shock. Now for EMS, this is kind of our criteria here for sepsis. Now it's a fever greater than what? 100.4. Don't call a sepsis alert on your patient who says, I run cold. 99.8 is a fever for me. It's not within the guidelines. A heart rate greater than 90, a respiratory rate greater than 20, and an end tidal less than 32, and a suspected or confirmed infection. Now, what they call the SIRS criteria is it's based on this criteria, and if you meet 3 or more of these criteria here, then you can go ahead and call your sepsis alert. And we'll talk a little bit later about our end tidal here and how that relates to our understanding and tracking of sepsis. So we have 3+ of these physical exam findings here. They can progress then to severe sepsis. And this is a confirmed infection. They have low blood pressure. their organs are not perfusing well, so you have renal failure. Your kidneys aren't working. Their urine output's going down. You've all seen them, those cold sepsis patients when they've started to progress into severe sepsis and septic shock. The tips of their fingers are blue. They're very just cold, and they look like a patient who is in shock because they are very close to being in shock. And when we jump from the idea of severe sepsis to septic shock is when we look at patients who have hypotension that stays. It persists even when we give them the appropriate amount of fluid resuscitation. So when you get past you maxed out on your fluid, you think, hey, this is what I need to do for these patients. You give them some fluid, give them some fluid, give them some fluid. Why is their blood pressure still in the toilet? They have progressed to septic shock. So in 2017, the Journal of Thoracic Disease came out with the QSOFA, which is the Quick Sequential Organ Failure Assessment. And this actually is a little more down and dirty, rapid look at is my patient in sepsis or septic shock. And instead of doing temperature and suspected infection, all those things, you have three things you're looking at. Is their respiratory rate up? Do they have altered mental status? And is their blood pressure low? That's it. And it's actually fairly accurate as far as determining if the patient is in sepsis. So we have our Get with the Guidelines. These have been revamped over the years. This comes from the Society of Critical Care Medicine, and it's also the European Society of Intensive Care Medicine. So both North American and European intensivists have sat down and said, hey, how do we take care of these patients through our Surviving Sepsis campaign? And it's actually uh-oh. Oh, good. Okay. It scared me. I didn't know. I didn't know where I went. Are we good? Checking. I want to make sure that we're still good to go. I'm gonna take a coffee. Okay. So from what I'm seeing from the YouTube, okay. All right. Awesome. So the Surviving Sepsis campaign has come out every couple years, and this is where we're at right now with the latest set of guidelines. So measuring the lactate level, that's not something that we can necessarily do in the field just yet with like point of care testing. However, we can use our end tidal, which correlates nicely to that. And again, that will be discussed in the next lecture. Get some blood cultures. Our service actually will do blood draws in the field for things like stroke, but as of right now, we can't do pre-hospital blood cultures. It's an issue of sterility and contamination of the samples. They consider, giving broad spectrum antibiotics before you have an idea of what's growing in that patient. Just shotgun them with some antibiotics and see if it works. Start giving your 30 mils per kilo per hour of, your 30 mils per kilo of crystalloids, so your normal saline if they've got low blood pressure. And if you give them the max fluid that you can give them, and they are still below a MAP of 65, then start giving some vasopressors. The ones that we as EMS can really step in and help with is that rapid fluid administration, and you can potentially do some vasopressors if you have like a push dose epi protocol or something like that, which Scott Weingart over at mcrit.org does a fantastic job of breaking down the importance of push dose pressors for emergency medicine and the emergency department and EMS. Docs have been using push dose pressors in the OR for 30 years, and he just thought, well, why in the world can we not adapt it to our department? And so now it's slowly filtering its way out of the hospital to the back of the truck, and it's a good thing. So all these guidelines started coming out in 2002, and there's basically been 4 stages. Stage 1, they wanted to sit down and go, hey, how big is a problem of sepsis? We know, we talked earlier, in the U.S., it costs us $20 billion a year. It's a huge problem. Not only a monetary cost, but it's killing people. We need to get ahead of it. So stage 2, they published the guidelines. Stage 3, they put the guidelines out and started collecting the data. And then stage 4, which is where we're at now, we're in the middle of the campaign reinvigoration. We are looking at our data and we are saying, how do we fix this for our patients? So now more into the EMS side of things. Yes, we're going to talk about lactate and capnography now. I love this stuff. All right, so glycolysis. That's our sugar. Our glucose is hanging out in our cells. It goes through a whole bunch of processes to produce pyruvate, and that goes into the Krebs cycle. Now, glycolysis, this pathway here is the same common pathway no matter if we produce lactate, like in sepsis, or carbon dioxide, like we have with our normal cellular respiration, that we're measuring when we throw our end tidal on. Where we start to differentiate is here. So the pyruvate will either, in the cell, either go into the Krebs cycle, and with oxygen, we'll get some ATP, some carbon dioxide. If our patient is poorly perfusing and they don't have the oxygen floating around that they need, then that pyruvate shunts over here into anaerobic or without oxygen metabolism, and we get our lactate, lactic acid. Now remember that we can only measure the CO2 production over here with our end tidal if we've got 2 things going on, and that's an adequate blood flow to the alveoli and if we open the airway. So yeah, those are a couple little caveats there for you. The big thing for EMS, though, is this right here. When we are looking at our pre-hospital care of the septic patient, as our end tidal levels go down, it correlates to an increase in lactate. All right. So we know here, this is where all of our sugars and stuff, our sugars are going in over here. They go through glycolysis, they hit the Krebs cycle. We're making the ATP, but right here is the important part. So if we have our oxygen and we are doing our things like we need to, we should be producing that CO2. If we're not, we're going back and we're getting that lactate and our decreased end tidal levels. So in the pre-hospital patient, remember that getting an IV and getting your what they call the early goal-directed therapy, they are predictors of decreased in-hospital mortality. So when we're talking, this is our fluid resuscitation, all right? And we have what we call as the number needed to treat, all right? So if we take, for instance, a group of 10 people and we apply the same intervention to them, how many people do we need to treat with that before they have a good outcome, all right? So with early fluid resuscitation, our number needed to treat is 1 positive outcome for every 7 people treated. So that's an okay number for pre-hospital. We need to be giving fluids. End tidal. Please, 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 if you suspect sepsis in your patient, put them on end tidal. They need it. They need it. They need it. If you can work with your hospital or your agency's infection control individual, work it out where you guys can get a blood draw kit. You're going to have some specific things like chlorhexidine in order to, clean the IV site well enough to where you don't get the staph on the skin down into your cultures. But those blood draws are very, very important. They can run those more quickly, and after they shotgun the patient with broad spectrum antibiotics in the ED, they can already have that blood sample cooking to narrow down exactly what antibiotic they need to give for the bug that they've got. And then your pre-hospital sepsis alert. If they meet that SIRS or that QSOFA criteria, even if you don't have a protocol for calling a sepsis alert, you can pass on to the hospital. Hey, I think this patient may be septic. This is what I'm seeing. They meet the criteria. Yes. So I forgot to take this slide out, and I'm sorry. We talked about this earlier. Your levofed needs to be at 65. I'll fix that later. So this is an example of my agency's protocols. And as you can see here, we have our probable sepsis patient. They have a suspected infection, and then they have the SIRS criteria. And really, this is just following the QSOFA. They've got a fever, they've got an elevated respiratory rate and an elevated heart rate, and then they have an N tidal of less than 25. They are producing more lactate than they are producing carbon dioxide in their respirations. So that's very, very important. And then obviously, you need to pay attention to your patient, and you need to be monitoring vital signs. Give them a bolus, and then give them a drip. And again, this is just an example of my agency's protocols. You need to follow your protocols for caring for your patients. Obviously, please don't go to your medical director and say, "Well, Connor told me to do this." I do not have the MD behind my name. Don't do that to me. And then, as we talked earlier, if you have a MAP below 65, keep giving them the fluid boluses. You may have to give them quickly, and if you don't have that option, then you may need to consider starting a pressor. And then, obviously, you need to transport the patient. Get an extra IV if you can, because you may need to actually begin another, basically dual fluid boluses, almost like trauma resuscitation back in the day. You're not gonna. This isn't overloading your trauma patient and they're draining pink Kool-Aid when you get to the ED. This is, you are filling that set of pipes that has expanded because of the sepsis. We are actually going to be here before too terribly long, changing our protocols, where if we suspect sepsis, we're not even going to do that stepwise management. It's not going to be, hey, we're going to max out our fluids first and then levofed. We're going to start them on a fluid bolus, and we're gonna hang a levofed drip at the same time. Levofed is a big one. Cardiogenic or septic shock. It acts by constricting that the vasculature and increasing your return to your heart and bringing the blood pressure up. Obviously, if your patient is allergic to the drug, don't give it to them. If they're hypovolemic, and it's not hypovolemia related to sepsis, if it's like a trauma, don't give it to them. They need maybe some push dose pressors. Those are very specific to our agency, and I'm not going to dive into those. So which is the best one, really? How do we choose our best pressor? So we need to be considering things, other drugs that patients may be on that can increase blood pressure and heart rate before we start giving these pressors. You really need to be careful with your patients that are on MAOIs. That's monoamine oxidase inhibitor, and the problem with your MAO is that's an enzyme that's found in our central nervous system and the blood vessels in our lungs, and it breaks down, a lot of important neurotransmitters. But in the central nervous system and the blood vessels, they can also break down adrenaline, norepi, and dopamine. So, you have to be very cautious when you give those two things simultaneously, because if they're on an MAOI, they're not going to break down the adrenaline, the norepi, and the dopamine. So if they can't break it down anyway, and then you hit them with norepi, you could have some pretty serious decrease in blood pressure to some pretty important organs, and get some end organ damage. But norepi is kind of the best of both worlds. You can see it. It gives us a little increase in the heart rate, not as much as like epinephrine or dopamine. It does more vasoconstriction. So the heart's already working overtime in your septic patients. Choose something that's gonna, kind of prime the pump by bringing blood flow back in, and that's going to be the peripheral vasoconstriction with your norepi. So some special considerations. Ooh, your patient who is septic, but they also have renal failure. Oh no, how are we going to do this? Do we want to overload them with fluid? Probably not. There was actually an ESRD patient study done in Lebanon in 2015. They had a very specific set of diagnoses. They looked for patients whose charts had a diagnosis of sepsis, bacteria, or septic shock. They pulled 90 patients out of there and they tracked everything. They did vital signs, they did lab work, they did time to antibiotic administration, they did 28-day mortality. Their set of patients was 41 male, 39 female. The average age was 70. How many little old people in sepsis do we run? They don't have the mechanisms as they age to fight off stuff. So it's something to be aware of. So of those 90 patients, 43% were bacteremic. The most common place that they got their infection from was dialysis catheters. And the most common infectious agent was E. coli and our old friend staph. Not Staph aureus like we talked about earlier, but a different type of staph. 20% of them required a stay in the ICU. Most of them stayed for over a week. 24 of those patients died. And our current recommendation says that, hey, we give our 30 mil per kilo bolus of fluid in the first 3 hours. And there were, in this study, there were people who were concerned of the kidney failure patients being over fluid overloaded, basically. And what they found was that led to they actually required higher fluids in the first 24 hours of their stay, and they found that they were severely under-resuscitated and there was a delay in antibiotic initiation. So even if they start to appear fluid overloaded, resuscitate them. If there is any concern, then you need to contact medical control and say, hey, this is what I've got. They're end-stage renal disease. I think they're fluid overloaded. How would you like me to proceed? Maybe they tell you to start some pressors. Maybe they tell you to hold off because you're only 15 minutes from the hospital. Don't forget that no matter what situation you're in, you can always rely on medical control to give you some help with that. Not that I'm trying to push your guys' critical thinking caps off on the doctor, but they are there for your help, but more importantly, they're there for the benefit of the patient, because that's what we're doing. So last little thing here, we do need to talk about an epidemic versus a pandemic. So when we think epi, think around or above you. Epinephrine is also known as adrenaline, right? Epinephrine comes from the adrenal glands that are above the kidneys. So epinephrine is above the kidney. So an epidemic is an outbreak of disease that it spreads very quickly, and it affects a bunch of individuals at the same time, but it's very, very kind of close in an area. So like if a country has an outbreak of a disease, and that would be an epidemic. pandemic. Do I even have to tell you guys about a pandemic? I don't think so. It's 2020. An outbreak of disease that occurs over a wide geographic area, and it affects a high proportion of the population. When we talk about pandemics, think of panning with a camera, right? You take your camera and you can, if you're at the ocean, you're going to pan across the horizon with your video camera. The diseases that cause pandemics, they go over the horizon. They jump out to places that you can't even see or think of. So that's the difference between the epidemic and the pandemic. That actually concludes my presentation, and also the things that meet the requirements for the National Registry's Infectious Disease and Sepsis module. I do have quite a few references here that you can take a look at. The infection prevention guideline, that's the one that I pulled the different like the bleach example out of. That's a really good supplementary document there for working on in infectious disease prevention in EMS. A lot of other references there. There's the QSOFA things there for you, and then there is some additional infectious disease information for EMS. So if you guys don't have anything else, we're going to take a little bit of a break, I think, and we will come back in a little bit, and we'll get started on our next presentation, unless anybody has any additional questions. I guess I should open the floor for questions, huh?
Connor, can you unmute my mic? Connor?
Oh yeah, I can do that.
Can you hear me? Connor, you there?
I'm here.
All right, cool. So I don't know about questions that you're receiving probably in the YouTube chat. Are you looking at that?
Yeah, I've got it pulled up right now.
Okay. So I see if I can get myself in frame here on the camera, and I don't have a good reference point to know if I am or not. But yeah, just to clear that up a little bit, we will take a break. So if you have questions for Connor right now, ask them through the YouTube chat. Connor, do you have the option to ask questions through your poll anywhere, or is that just for?
Yeah, the poll anywhere is just basically through the for the stuff in the presentation.
In the presentation, okay. So
if they
questions.
have any other questions, you can just put it in the YouTube chat.
Right. Okay. All right.
Get for you.
Right. Just clearing that up. So if you have questions for Connor, put them in YouTube chat. Give that a few minutes to work itself out there and see if you have anything for him to give him a chance to answer. We'll take a little pause, let him kind of reset for capnography, and we'll come right back. All right, folks. I don't know if there's been any questions or not. We'll go ahead and sign off on the stream for the moment. We'll just stay close to your favorite device. We'll activate a stream here in just a few minutes. We have Connor back again with us for capnography. You can't see the screen now. You're looking at my leg probably. So capnography, and then after that we have a physician that'll be here in the room live with us. So we'll get capnography done, and then we'll get on to the next for lunch, before lunch. You know, really, there's no reason to end the stream and come right back in a few minutes since Connor's ready for capnography. Connor, are you still there? I'm just gonna leave the stream going. I've currently got the camera panned down towards the table there, the tablecloth, but a little branding going on. I didn't have
Yes.
the sound on. So anything you just said verbally to James's question, you didn't hear.
Okay. You were asking about the amount of deaths if these patients received the sepsis diagnosis in the ED or after admission. Off the top of my head, I believe that those diagnoses were admitting diagnoses from the ER doc. So I'm pretty sure that the ER doc was the one who said, "Hey, this patient has sepsis," and then those patients went on to have a third of them die after admission. So, like I said, it's a big problem, not just in terms of the financial costs in the U.S., but also in terms of cost of life as well. So, if nobody else has any other questions, we'll kick off this presentation here on capnography. So, won't bore you guys too much with my presenter information again. But a caveat that I did not include in the first presentation is that this presentation is solely my own, and any opinions, data, etc. Presented here are a representation of myself and not those of my employer. So, yeah, don't call my boss and be like, "Hey, Connor said." All right. So these are objectives for the day. Again, primarily we're working on satisfying the National Registry core component of capnography, and that is there because a lot of you guys are nationally registered. So trying to take care of that for you in addition to your state licensure. We're going to discuss why we need capnography, the history behind our capno, the equipment utilized in it, who utilizes capno, and the waveform in our various disease processes. So, ventilation versus oxygenation. Ventilation is actually where we move air in and out of the respiratory system. It is our act of breathing. We take the oxygen from the atmosphere and we inhale it to the alveoli, and then we take our carbon dioxide from the alveoli and we exhale it back into the atmosphere. All this can be changed as a result of things like asthma, COPD, edema to the airway, if you have a foreign body, airway obstruction, things like that. Now, the oxygenation is the movement of the actual oxygen from the alveoli, you can see it right here, from the alveoli down into the pulmonary capillary, and then it goes through to keep the cellular processes running in the body, comes back as carbon dioxide. Carbon dioxide goes into the alveolus, and out it goes. So, now the important thing here is we need to discuss diffusion. Now, diffusion is actually how the oxygen and carbon dioxide move across the alveolar wall and the capillary wall there. And so anything that is going to increase that distance necessary for those gases to diffuse is going to cause oxygenation issues. Whether that's the fluid in the alveoli from pulmonary edema, if there's chemical damage to the alveoli, if there's carbon monoxide poisoning, infection, all those kind of things. So it's important to remember that those movement of gases is changed by that alveolus. So there's a bunch of stuff that can lead to poor perfusion, and we have to realize that oxygenation and ventilation are both intimately tied to perfusion. So anything that messes with the blood flow to our alveoli is going to decrease oxygenation, and that can be a pulmonary embolus. So you have a blood clot that is preventing blood from circulating around the pulmonary vessels. Shock of any kind that leads to hypotension. If you don't have any blood there, you're not going to carry your oxygen. Cardiac arrest, cardiac dysrhythmias, and the like. So when we're talking about capnography, where does that word come from? Well, the word itself is Greek. It's kapnos, and it means smoke. So you can think of this as carbon dioxide being the exhaust from the engines of our metabolism, right? So we are taking the byproduct of all of our biological processes. In this case, it's going to be carbon dioxide, and we're measuring that with our end tidal. Now, we discussed this in the last lecture. We have sugar that is going to undergo multiple reactions to produce pyruvate, which goes into the Krebs cycle. Now, depending on whether or not we have oxygen or no oxygen, determines our final product. So, if we have oxygen, we're undergoing aerobic metabolism. We're going to produce ATP. So we got our energy going on, and we have carbon dioxide that we're going to measure with our end tidal. If we're undergoing anaerobic metabolism, no oxygen, then we're going to produce our lactate or our lactic acid. All of this is occurring in the cell, and remember that if we're going to measure this carbon dioxide over here, we need to have adequate blood flow to the airway, and we need to have an open airway as well. Hi, Mendicott. Hi, Pendicott. Good to see you guys. You're about the only ones I'm going to give a direct shout out to, but I digress. So let's do a little bit of a visual representation here of our carbon dioxide and our ATP, right? So here we have our forest. That is our big molecule of glucose. It really can't do anything. It's just hanging out, right? Now, when we go through the Krebs cycle, or not, when we go through glycolysis rather, and we chop up our wood, then this chopped wood is pyruvate. Okay, it's been broken down into something that is usable now. So we are going to take this pyruvate and we're going to throw it into our Krebs cycle, and that Krebs cycle is a fire. All right, we're going to burn some things, and we're going to make a couple things with this fire. The smoke that we get is our carbon dioxide. The ash that is left behind is our ATP. So just think of that visual representation. We go from a forest that's not really a usable molecule all the way down to the byproducts. So why do we need capnography? All right, we monitor every other vital sign when we're doing things like sedation. So why do we need capnography? Let me give you a case study. This was from it was either 2010 or 2011, and it was an incident in Minnesota. There was a 54-year-old male who was heading into the grocery store in Minnesota, and he was going to purchase a propane tank for grilling. I'm sorry, there is a thundering herd of my children upstairs, so that's coming through. I apologize. I thought my bunker was more soundproof, but I digress. So he's going in, he's going to get some propane to grill, and he collapses in the doorway. And somebody there immediately begins CPR when they saw him fall, and 911 was called. Now, this was kind of a more rural area, I guess. There were 24 bystanders and EMS personnel who provided continuous CPR until a helicopter crew arrived. Okay, so you've got EMS there, you've got your helicopter crew, they're all working together, multidisciplinary. The guy's in a VFib arrest. He has great capnography. Okay, it's reading well above the 10 millimeter mercury cutoff that we'll talk about later. And his efforts were continued. Were continued, and they contacted medical control, and the doc said, you guys should just go ahead and terminate resuscitation. The team on scene was highly uncomfortable with ceasing the resuscitation, given the fact that he remained in a shockable rhythm and his capnography remained high. So they actually kind of stepped outside their chain of command, which again, caveat, don't recommend doing, but you have to fall on your sword if things go poorly for you. But anyway, there was a medic on the helicopter crew. He called a well-known anesthesiologist and expert on resuscitation, and he advised that they continue. And there were multiple phone calls made throughout this resuscitation. Everybody started to want to give up on this guy. They did 12 defibrillations with high quality CPR. They coded this man for 96 minutes. He had a good neurological outcome and actually ended up walking out of the hospital 10 days later with no deficits. So when we look at our capnography, we need to realize that our changes in capno, they are tied into our oxygenation, right? So we have pulse ox. Why do we need to worry about capno? Pulse ox can take up to 5 minutes to measure changes in oxygenation. So you have to have the time for the oxygen to be uptaken into the red blood cells. You have to get it all the way down to the tissues where it's measured by the red light sensor that measures the saturation. End-tidal, however, can actually measure changes in ventilation within 10 minutes in the change of ventilatory status, right? We've all had that patient who you're going along and you're watching their end-tidal and all of a sudden it's like apnea alarm. You're like, oh, okay, well, let's start bagging the patient. That's not going to happen with your pulse oximetry. It's just not. And so intervention in a respiratory issue can occur much more rapidly with capnography, and you're going to see a decrease in adverse outcomes. There was a study done in 2010. It was what they call a meta-analysis, where they take other studies and they dive into the data in those studies. There were 5 studies included here, had a total of 322 patients. And when using capnography, they were able to notice and identify respiratory depression 18 times more frequently when capnography was used in procedural sedations than if they were using pulse oximetry alone. There was another study that was done. It was a randomized control trial, and it had 232 patients, and capnography identified all cases of hypoxia before onset. So before the pulse oximetry even started to dip, they were able to notice the respiratory depression with their capnography. The median, the average, the middle time from noticing the respiratory depression with capnography to noticing the respiratory depression with the pulse ox was 60 seconds. So almost a minute ahead of the pulse ox changes, they were able to catch the respiratory depression with capno. So use it, please. So let's do some definition here, right? So your capnograph, that is the graphical measure of a single breath. So that is your box waveform that you see when you're looking at your capnography. Your capnometry, that is your end-tidal number. All right, that measures your end-tidal carbon dioxide concentration numerically only. So that's your 22 millimeters of mercury that wants you to call a sepsis alert. And then your colorimetric capnometer does both the number and a waveform. So as we talked earlier, the pulse ox measures the transport of oxygen in your arterial blood, right? So you have your oxygen in your lungs. It's in the alveoli. It diffuses across the alveolar wall and the capillary wall, gets into arterial blood, flows along into the terminal capillary circulation down at your earlobe or your finger or whatever, and that's how you get your pulse ox reading. Okay, so we also need to differentiate that oxygen in the lungs in the alveoli from the oxygen in your trachea and your bronchi, right? So this becomes important a little later. Any place where gas exchange does not occur, right? So your oxygen doesn't move into the circulation and your carbon dioxide doesn't move out of the circulation. Those regions are called dead space. No gas exchange is occurring there, and those are places normally like your trachea, your terminal bronchi, before you get to your alveoli, way up in your airway. That becomes important when we talk about this physiologic dead space in some CAPNO waveforms later. So remember, we're looking at the end of a biological process. So we go from glucose, and depending on what's going on with oxygen, we either produce carbon dioxide or lactate. So the capnography, again, measures the product of a series of biochemical reactions, and it's a measurement of our exhaled carbon dioxide. So some finer physiology points. All right, so we're talking about our normal end tidal levels. They're normally between 35 and 45 millimeters of mercury. And if you have a patient who is hypoventilating, so they're not breathing as much, they're going to be elevated because they're just not blowing off their carbon dioxide. If they are hyperventilating and they're breathing too fast, they're going to blow it off pretty quick. And so they're going to have a decreased end tidal. It's going to be below 35. Now, the pressure of your carbon dioxide in your arteries is a little higher than what you get on end tidal by about 1 to 5 millimeters of mercury, and that's okay. We can still utilize end tidal and not be super concerned about that PaCO2. So, the end tidal is a pretty close approximation of what our arterial carbon dioxide levels are. So, yeah. When we are looking at our arterial concentration versus our end tidal concentration, that kind of that breadth between the two will increase as a patient gets older. So they will, if they have something like COPD or emphysema, they will actually retain more carbon dioxide in their arteries. And so you will have basically a larger arterial carbon dioxide concentration versus your end tidal concentration. So how long have we been following the idea of carbon dioxide? So we go back to ancient Rome, to the Grotta del Can, the cave of the dogs. This is a little cave in a series of mountains near Naples, Italy. And down inside the cave is actually, it would best be described as something like a hot spring that releases carbon dioxide of volcanic origin. And oh man, you cannot get away with this at all. So what they used to do this occurred until the 1870s, I think. Local tour guides would take a small animal and would put a small dog, which is where they got the name, the Cave of the Dogs, put it on a leash and start carrying it down into this cave. And they would take people who are wanting to go on this tour down with them. Now, what would happen here is, you can see, here we have our human, right? And here's our little doggy. Carbon dioxide is heavier than air, all right? And so they would start walking down the cave, and the concentrations of carbon dioxide would grow and grow and grow and grow. The human is still breathing normal atmospheric air up here because they're, taller than the tiny dog. But as they continued down, the dog would become more and more hypercarbic and eventually would either pass out or die. They would actually, if the dog was not dead, they would pull it out of the cave and they would throw it in a lake nearby and revive it. And it was finally stopped, thank heavens, in about 1870. The lake that some of the water and stuff was coming from was polluted, so they stopped it. But it's being restarted by volunteers. Yeah, I don't know why they would do that, but yeah. Anyway, Mark Twain actually traveled there in the 1860s and saw it. So yeah, it was investigated by cave divers and stuff, and it was discovered that the carbon dioxide level was about 9.9% down there in the bottom. A concentration of 5 to 10% produces panting and fatigue in humans, and anything that is greater than 5% will actually produce irreversible health effects and can cause unconsciousness and death. So, yeah, don't take your purse puppy to that cave. It's a bad idea. Bad idea. So there's the outside of it, and that's what it looked like. And yeah, just yeah. So, in 1600, there was a Dutch physiologist, Van Helmont, and he noticed that if he burned wood, he would get a change in pressure and volume in whatever he was burning the wood in. And he said, I call by this new name gas. So he knew that there was something there. There was something that was produced by the burning of wood. He called it gas, but we didn't know at that time the actual structure of it. Now, Joseph Black was a scientist in the 1750s, and he discovered what he called fixer air. And this was carbon dioxide as well. He would burn magnesium carbonate, and he noticed that if he put a candle in like the bottom of a bell jar, that this gas would kind of float to the bottom. It was heavier than normal air, and it would burn out the candle. And it would also, like the cave of the dogs, it would suffocate animals. So yeah, there's been a lot of kind of terrible animal experimentation done as a forerunner to capnography, and I'm glad we don't do that anymore. And I'm also glad that we don't put this in the back of our ambulance. So this was John Tyndale's device, and essentially what he would do is he would put carbon dioxide in a tube. He would seal off both ends, and he was able to measure the amount of carbon dioxide contained in there based on how light flowed against a photographic plate. I'm not going to get into the nitty-gritty of it because I don't understand it all that much either. But yeah, Nate, it's not as dark as suffocating dogs in a cave. So a little bit lighter, trying to keep things positive. So Haldane came along in the late 19th century, and he actually began measuring the volume of carbon dioxide. And he would use chemical absorbents, either potassium hydroxide, sodium hydroxide, and he would measure the volume of change of those two things at a constant temperature and pressure. And through the chemical reaction of the carbon dioxide with those two chemicals, he was able to determine how much carbon dioxide was present. And he also was the first person, this is very important, to describe that breathing is triggered by carbon dioxide rather than a lack of oxygen. That's what prompts us to take a big deep breath, is the sensors in our neck and our aortic arch to go, whoa, hey, that carbon dioxide is way high. You go ahead and take a big breath. 1900s, Douglas bag method. This, for the long time, was what was considered the gold standard of carbon dioxide measurement, and there was exhaled air that was exhaled into a large impermeable bag, and then they could determine the fractions of the gas that were in there. So carbon dioxide, oxygen, nitrogen, those things, by squeezing the bag through a device called a spirometer, and that would give them an idea of how much gas was in there. So it provided a number. It would give you a number of your carbon dioxide, but it wouldn't give you a waveform. And then in 1928, the volumetric capnogram came out. This was done by the U.S. Air Force, I believe, and it measured the volume of air expelled and then the pressure of carbon dioxide. And you guys will notice this is beginning to look more like a capnograph waveform. So, in 1943, we had the development of the first infrared CO2 monitoring device. So, capnography itself has been around for a while. As far as the technology, it's just become a matter of getting it more portable, which that came along in the 1950s. And the Army was the first group of people to actually produce the capnographic details of the respiratory cycle. So it was in an anesthesia publication in 1961. They came out and said, hey, this is what a single breath looks like as far as carbon dioxide production. When it comes out and it plateaus, and then they take a breath and it goes down. So they came out with that in 1961. Now in 1976, we have the Model 930 commercial volumetric capnograph. Obviously, this is, again, going to be something that is hospital, not pre-hospital based. It was utilized in the operating theater for monitoring carbon dioxide levels. Now, in 1978, Holland was the first country to jump on board and say, hey, when you have a patient that is undergoing anesthesia, they need to have capnographic monitoring using, I believe it was that bad boy right there. So they wanted to do it, and they said, okay, let's go ahead and make this a standard of care. And if they're undergoing anesthesia, they need the capnograph monitoring. So in the 1990s, we wound up with our D-light sensor, and now they're putting out the side stream versus mainstream gas sampling. And so we will talk about mainstream versus side stream right now. So these are our two capnographs here. We have our mainstream capnograph, and in this case, your infrared detector is built into your circuit. So you have your patient that's breathing out, carbon dioxide comes out, goes past the sensor, you get a reading on your display, carbon dioxide goes out and is exhaled through the circuit, versus the side stream, which they exhale through the endotracheal tube, and there's an adapter here that actually takes a chunk of that gas, samples it out, sends it to a display, and then the remainder of the gas is sent out through the circuit. So that's what we have with that. So as I said, the mainstream detector is there between the tube and the ventilator. It's a good one for neonates and kids, and it also gives a little bit more crisper display, and you can do some more real-time trending of the CO2 levels, simply because it's just reading it right there as it's going past. It's not having to go out to another thing and be processed, essentially. Because the side stream, like I said, it takes a sample and goes along another circuit to the detector. It takes more time for it to reach that detector, so there's a lag in the reading of the CO2 levels. And it's also prone to some pressure drops. Also, if you get water vapor in the exhaled air, that can cause some problems there in the sampling adapter and tubing as well. So mainstream anymore, kind of the way to go. So we talked earlier, here's our colorimeter, right? That thing, the one that changes color. Remember, yellow good, purple problem. Excuse me. So with the litmus paper, if there's a yellow color change, it means that there's more than 2% carbon dioxide in the breath. If you have a patient who has aspirated a bunch of Dr. Pepper with a bunch of carbonated beverages in the lungs, then you'll get a false color reading there. It's worthless if wet. It's paper. If you get excess moisture in there, throw it out, get another one, because it's not going to work. It's used for short-term detection only. That continued exhalation, we've all got water in our exhaled air, and so it's going to make that litmus paper wet, and it's just worthless. They've got expiration dates, and some studies show that there's a failure rate of up to 13%. So these are kind of falling out of favor. Then you've got your capnometer here in the middle, and that just displays, like I said, a number there. And then your capnography gives you both your number and your graph. So in hospital, the American Society of Anesthesiologists actually says that capnography is not mandated, but it is strongly encouraged. I would hope to see that change here before long. Now, Joint Commission, our dreaded nemesis, the Joint Commission, says that capnography is standard of care for sedated patients and it has to be uniform throughout the institution. So, if you're using capno in the ICU, then you need to be using capno in the ED. All right. And again, it's good for your ventilated patients and whatnot. So now we're going to jump into our my agency's equipment here in Reno County. We use the Zoll X series, which I think you guys are still utilizing at NCAD. So here is your side port there. So there's your little door with your waveform capno. Slide the door down right there. All right, you connect it. Go in, turn on your CO2 monitor over there on your left-hand side, and wait for that bad boy to calibrate. It will initialize, and you'll get it going. Now, as far as other equipment, you can actually utilize waveform capnography in your ventilations with a BVM. This is important to make sure that, using the old way of, chest rise and fall and things like that is good. Don't get me wrong. It's still important to make sure that you're not, overventilating and producing gastric distension or anything. But we can also use the capnography as an adjunct for our BVM ventilations. And so you can put your ET tube sampler between your BVM and your actual mask, and you can monitor your respiratory rate. You can monitor your hyperventilation in your brain injured patients, those kind of things with that. Again, when you drop your tube, it's easy just to switch them out. You toss your ET tube on that after you pull the mask off, and you're good to go. Here is the this is CPAP here, and this is our particular device. It's a little less cumbersome than others that are out there, and you can actually, in this area, put your capnography between the connector and your CPAP mask as well. So that'll help you. All right, let us talk about our waveforms now. I'm going to have to hustle because I feel like I'm talking kind of slow, and yeah, anyway. So this one waveform here shows one respiratory cycle. So here is our exhalation, and so exhalation right here and inhalation right here. This part of the plateau right before we take our breath, our inspiratory phase, that is the end tidal carbon dioxide level, right? So you have your millimeters of mercury, and time is over here. Now, the printout that you get is in real time versus what you see on your screen, and your screen is just like a 4-second snapshot. So if you're wanting to trend things, you can go ahead and go in and hit the printer and start printing, and it'll give you kind of a trending that you can look at. So phase 1 right here, this is our end of our inspiratory phase. It's right before we start exhaling, and this is our dead space. All right. This is the air that is in our nose, our mouth, our trachea, our bronchi. There's very little CO2 there. All right. Now, when we start to exhale, we start to see kind of a slow uptick, and this is a mixture of that dead space gas and the CO coming out of our alveoli. And then we see a real quick uptick in the exhalation, right? And then it starts to plateau as we're coming up to the end of our expiration. This is all of our alveolar gas. It should kind of stay the same all throughout, and then we take a breath, and it goes away. right? So this PETCO2, like I said, is our end tidal. It's the end of the cyclical or tidal volume of inspiration and expiration. This alpha angle right here, that represents what's called our VQ status, our ventilation and perfusion status. So if you have somebody who has, for example, a pulmonary embolism, they are going to have okay ventilation. They can move air in and out, but they're not perfusing. There's no place for the blood flow to go. So you will actually get this angle here will increase to over 90 degrees. And that is an indicator of a VQ mismatch, usually the result of pulmonary embolism. So let's talk about this in the intubated patient. This is our primary use of end tidal in EMS. There's other uses that we'll talk about in a little bit, but yeah. The flat line. Minute amounts of carbon dioxide in esophageal intubation. Yeah, that's it right there. It's going up a little bit because we do have a little bit of CO2 in our gut, but not a lot. So this flat line here is usually the result of the machine auto-zeroing out before you put the end tidal cannula on the patient. It can also be the result of a disconnected circuit. You can have a patient who has lost their airway, so they have gone unconscious. They've lost their pharyngeal tone. Their airway is occluded with the tongue. You don't have an airway anymore. It can also be the result of a code, or they're just not breathing at all. And so, these are some pretty heavy hitters. Your loss of pharyngeal tone, your code blue, you've intubated the esophagus. Those are important things to take a look at and try to troubleshoot. So this right here is esophageal intubation. We can see here where the patient was initially being probably bagged, and it was being monitored through the BVM. And so as we're bagging, we can get some air, some carbon dioxide pushed down into the esophagus if we're over bagging. And so we drop the tube, we start bagging, we're like, okay, good, we got good waveform. Okay, it's dropping. All right, why are we not getting? Okay, there's no chest rise. And essentially what you're doing is you're washing out that carbon dioxide. The CO2 that you have pushed down into the esophagus during your pre-intubation oxygenation phase has been washed out, and now you are in a flat line because you no longer are getting any CO2 out. You've intubated the esophagus. So check that tube. Check it. In field EMS, we can use it to assess the quality of our CPR. There was a study done in 2001, and this is kind of what started pushing our move into utilizing end tidal for arrests. There were 139 out-of-hospital cardiac arrests in the study, and no one with an average, initial, or final end tidal less than 10 survived. Okay, so 10 is not good. If you're doing adequate compressions, you should have an end tidal greater than 10. Greater than 20 is a lot better. Also, if you see an abrupt rise in your end tidal, that should make you consider checking for a pulse and considering ROSC. And when to call a code, if you have consistent end tidal less than 10, despite adequate compressions and an adequate airway, if that is less than 10 millimeters of mercury after 20 minutes of resuscitation, there is a 100% mortality for that patient. Now, also, experienced EMS providers can use CAPNO to differentiate between different disease processes and kind of guide treatment as we're going along. So going back to CPR, here we have what we have up here is a change in the compressor. So you'll notice that at point A, we start seeing a decrease in our end tidal, and we switched out and begin new compressions, and it comes back up. Please note, though, that with a change in compressors, or this also goes along with your pulse checks, it takes some time to build your end tidal back up, and as it kind of correlates with your pressures. So it takes a while to build up your blood pressure to return the blood to the lungs to get the CO2 out. So pulse checks, changing of pressures, you have a drop in your blood pressure as well as a drop in your end tidal. So something to consider. Stay off the chest for as little time as possible. This bottom one, ROSC, you can see here they're going along. Yeah, 10, 12. Hey, we have a sudden increase in this. Perhaps we need to check a pulse at the next pulse check. So if you have no chest movement along with an apnea alarm and a decreased end tidal waveform, then you should consider it to be apnea, right? But if you see some chest movement, the patient's still trying to breathe, but you suddenly have a drop to 0 in your end tidal, then you're looking at something like a laryngospasm or an upper airway obstruction, and you need to address that quickly. There was a cadaveric study done in 2017, and what they noticed was they set out to determine, can we use capnography to determine if we have proper tube placement even when there is no blood flow going on. Okay, so you have a patient who's in cardiac arrest. Can we make sure the tube is in the right way? And what they found is that even with CPR, if there was a low end tidal reading, or if it showed that decreasing waveform, then it was 100% sensitive and 100% specific for esophageal intubation. So if you see a decreasing end tidal and it drops to 0 and you've tubed a patient, think esophageal tube and fix it quickly. All right. So hyperventilation. We see decreasing levels of end tidal CO2 with each breath. All right. They are breathing too rapidly, so they do not have adequate gas exchange, and so there is not enough carbon dioxide coming out with each breath. Hypoventilation, complete opposite. They are breathing more slowly, and so they are not exhaling as rapidly, and so they have an increase in end tidal with each subsequent breath. So there's our intubated patient. Let's talk about our non-intubated patient. This is where things get kind of fun. We can start looking at different disease processes. So bronchospasm, right? Why do we get that shark fin that is burned into everybody's mind when we talk bronchospasm? Well, it's because you're still trying to get the carbon dioxide out from your last breath, right? So you still got that dead space mixing of gases. You're trying to breathe against basically a straw because you're trapping gases there in the alveoli, and so it takes longer for the carbon dioxide to come out, and then you take a deep breath. All right. So not only do you get this from COPD and emphysema, but you can also get it from asthma or a kinked ET tube. Someone upstairs just put their shoes on. So here in our first end tidal, you'll notice that there is a decreased level here, and the waveform is long. It is taking a huge amount of time for them to try to breathe. They are in almost complete bronchospasm. Okay. Now we see here that the albuterol and ipratropium is starting to work. It's starting to take on that kind of shark fin appearance. It's still long, but it's becoming more elevated. And then finally, we're beginning in this bottom one to see after 2 duonebs, you'll see a normal kind of box-like structure there to the waveform. So what they're doing here is working. If it wasn't, I'd probably give them some mag. But anyway, emphysema sometimes will look like this. And emphysema is the destruction out of the alveoli. And so because so many of the alveoli are kind of collapsed and destroyed and stuff, there's not as much distance for that CO2 to go, so it kicks that carbon dioxide out very quickly to the airway. So you see a very, very rapid high rise in your end tidal, but then there's a negative slope here. And why is that? Well, that's because you are trying to exhale past kind of the trapped closed airways, and so you will quickly, very, very quickly, breathe out the carbon dioxide that you can, but then there's still a little bit filtering out, and it's still coming out slowly as you are taking a breath. As you are still exhaling, it's slowly filtering out, but it's not coming out all the way. So you don't get an increase there before you take that next breath. That is something that I need to find a better way to describe that to you guys. So try to get something out to you about that. Elevated baseline, right? So this is where we are. This is our 0, and you'll notice that as the patient continues to take breaths, when they return to baseline, it's not going back down to 0. So they are trapping air there, and there's one of two things going on. They are either stacking their breaths, so they are not getting all of their CO2 out before they take their next breath. So there's some residual left in there that's elevating the baseline, or they're rebreathing CO2. There's a problem with your ventilator circuit. So pull it, get a new ventilator circuit, bag them for a little bit, make sure that they're washing all that CO2 out before they move on. Okay. So a pneumothorax, man, a pneumo, whew, it looks really weird on capno. It does. So a pneumo can look like anything. It can. It may be a normal shape, but it may have decreased end tidal levels, a shorter waveform. So you've got a box but the box is shorter, and that is essentially due to the pressure around the lung is squeezing the lung tissue, right? Okay, so as it develops, their cardiac output is decreasing. The volume available to their lungs is decreasing, and it's all due to the increased intrathoracic pressures as a result of that tension pneumo, right? And so they don't have an airway obstruction going on, so you don't get the shark waveform. Instead, you get a normal waveform but decreased levels because they can't take a big enough breath to get CO2 back into the lungs to exhale. And you can also find it with your BVMs as well. If you are giving a big, heavy, hard breath, you can cause a pneumo and increase that intrathoracic pressure there. So as the size of the pneumo increases, though, it can start to compress the airways as well. Remember when I said that the pneumothorax on capno can look like anything? As it compresses the airway, you can actually start to get a bronchospasm appearance as well. So it's all over there. So this is an example right here of our pneumothorax waveform. You can see that it kind of should take on a box-like structure, but you're getting the decreased end tidal over time because of the compression of the airways in the lungs. So we've talked about cardiac output in capnography. We know in arrests that a sudden increase in end tidal should make us think that the alveoli are being perfused well, And as a result, if they're being perfused well, it's probably not our compressions. We probably have a heartbeat again. So we need to evaluate that as well. Capnography and cardiac output. You guys will remember last year I talked to you guys a little bit about this in my heart failure lecture, but remember that carbon dioxide is soluble in water, right? So it will, even in heart failure, that lung alveolus can be filled up with water, and that carbon dioxide is still going to get through because it can move through water, right? So you don't have a bronchospasm going on here, all right? You may hear some wheezing. All that wheezes is not asthma, but you have a normal capnograph, okay? So you have a normal waveform shape. Now, depending on how tired they are, you might have, a decreased respiratory rate or a decreased volume from hypoventilation, but you are going to have a normal box-like structure in your heart failure patient. DKA. We've evaluated DKA in peds for a while, but this 2015 study decided to take a look at adults. They had 71 patients of which 21 were in DKA, and they noticed that a patient who had a blood glucose greater than 550 and an end tidal less than 100, and an end tidal less than 21, it was specific 100% of the time for DKA. They did some additional tests, and they have discovered that if a patient has an end tidal greater than 35, it is 100% of the time specific for ruling out DKA. And basically, kind of how this comes about is they're low on insulin, so they can't metabolize their glucose, right? So instead, for fuel, the body switches over to fat metabolism, all right? So they start producing their ketones. Ketones are acidic. It produces an acidosis. They start kicking out or trying to kick out the blood, trying to kick out those ketones in the urine. They can be dehydrated, all these wonderful things. But the big takeaway is that if you suspect DKA, if they have an end tidal greater than 35, you can pretty much rule that out. Sepsis, we talked about this earlier. End tidal is a wonderful surrogate for metabolic acidosis, right? It is super expensive to get lactate testers out into the field, right? But we know that there is an inverse relationship between our lactate levels and our end tidal, right? So patients who die of sepsis, they have lower end tidal levels on arrival in the emergency department. This was a 2013 study done by Hunter et al. And if you have an end tidal less than 26, your chances of surviving your septic event are pretty low. In 2016, Hunter also came out with the sepsis criteria triggering a sepsis alert. We have our suspected infection, meeting 2 or more of our SIRS criteria, and then the big thing here, if that end tidal is less than 25, consider calling your sepsis alert. It's pretty sensitive. It's about 90% sensitive to being septic. Mass CAS and bioterrorism. Triage process, right? Okay. Since 2011, EMS has been focusing and preparing on a terrorism event causing an MCI. You guys know, unfortunately, we all know that our MCI doesn't necessarily have to be, from terrorism. In our case, it was weather, and we can utilize capnography in assessing and triaging our patients. It is a super quick modality that can measure our ABCs in less than 15 seconds, right? You throw it on there, they've got a normal end tidal between 35 and 45, they've got adequate ventilation, adequate perfusion, right? We can take a look and see, hey, have they been exposed to something that is producing hyperventilation, hypoventilation, a bronchospasm, things like that. So yeah, throwing capnography on your MCI patients, it can very quickly help you rule them in or out in the triage process. It's been said that EMS systems should consider adding capnography to their triage and patient assessment toolbox and emphasize its use during educational programs and MCI drills, right? So let's talk about troubleshooting. We're in the home stretch, guys. I'll get you out of here hopefully very soon, I hope. So if you see a sudden drop in your end tidal and it goes down to 0, you need to start thinking of something that is preventing your exhaled carbon dioxide from getting to your sensor. You've either got a tube that's messed up, it's kinked, you've got an esophageal intubation, there's a disconnect from your ventilator, your patient's not breathing, those kind of things. Now, if there's a sudden change and you are not returning back to 0, then you need to consider that you've got a calibration error and there's condensation in your tubing. If there is a kinked ET tube, just like a kinked airway, it's going to look like a bronchospasm there. So before you throw a duoneb at this guy or gal, start thinking, as I'm bagging them, is there resistance? Is there a decrease in chest rise and fall? Am I not hearing good breath sounds? Think equipment, not bronchospasm. You can also see some increased CO2 with fever if you have a sodium bicarb administration, release of a tourniquet, all those wonderful things. If you got a patient with malignant hyperthermia, that is a genetic condition where with certain anesthetics, they can have insanely high body temperatures. It can put them into like a hypermetabolic state, and you'll have end tidals in the 50, 60 mark. Also, if you're looking at an increased EtCO2, you can have issues with your ventilation of the alveoli. Do you have hypoventilation? So are they not breathing off enough carbon dioxide? Do you have your ET tube down in one of your bronchi? Is there an airway obstruction? Things like that. Are they cold? If they're cold, you're going to have a decreased CO2 production just because the body's not working the way it should. And as a result, you're going to have a decreased EtCO2. Is there a is there a pulmonary perfusion problem, right? So is their cardiac output down? Are they code blue? Is there a pulmonary embolism? Those wonderful things. So the pulmonary embolism, it's going to reduce your end tidal CO2. But think about if you see somebody in the ED getting treated for a pulmonary embolism, and all of a sudden they get a jump in their end tidal, it's likely a sign that the clot is dissolved. Your decreased levels as well of end tidal CO2, you've got they're hyperventilating, they're apneic, they've got a total airway obstruction, but they've also got a high airway pressure. You're trying to bag them in and you've got no compliance whatsoever. So we have our differential diagnoses when we're sedating people. If we've got an increased CO2, we need to consider that they're hypoventilating. If there's no CO2, then we've got some kind of obstruction or they're not breathing. And then if it's decreased, we have a whole manner of hypoventilation. There's a wonderful diagram here. You guys can clip this out and take a look at it, and kind of go down this pathway as you're troubleshooting things as well. Emerging evidence, our trauma patients. There was a case series done that was over 1,100 patients, and when these patients arrived in the OR, if they were having an end tidal less than 20 within 5 to 10 minutes of arriving at the OR, then they had 100% mortality. So consider that when you're treating your trauma patients. ECMO. Do we have patients who can benefit from ECMO? Probably. In the patients who are not responding to normal therapies of just regular ACLS, then you can consider using capno in your ECMO as well. So that's something that's more in hospital. There's some evidence coming out, but there's more studies that need to be done on that. So I want to thank Jeff for letting me come in and give both these presentations today. It is greatly appreciated. I would also like to thank my wife, Dr. Bounds, there at Salina Regional. She graciously let me swipe this presentation from her from residency and tweak it and turn it into my own. And so, yeah. If you guys want some additional resources out there, emdocs.net. They got some great stuff on interpreting capnography, including some pearls and pitfalls from both of them. Here's all my references, tons of them. You guys are awesome, and thanks for letting me be a bit long-winded. And you guys have any questions, shoot them here. And yeah.
Any questions popping up on you? My transition from the other room to here, was this a question answer time? Connor, can you unmute me on the Zoom? Or maybe I can myself. Connor, are you there?
Yes, I am.
Hey, Connor.
That is all that I have for you guys.
Okay, excellent. Was there any questions popping through? I can't actually see that right now. So if anybody has questions, now's the time to ask Connor. Otherwise, Connor, thank you very much for your time.
Yeah, you're welcome. I appreciate it. It's always a great opportunity. I'm thankful for the opportunity, definitely.
And we appreciate you. Excellent presentation, sir.
Thank you. I'll hang out here for a couple minutes, and I'll actually just be watching the YouTube chat as it's scrolling through, and I'll answer any questions there.
We're gonna leave the stream live. We have our next presenter in the building, so we're gonna probably move the camera angle and get her set up. But we'll leave the stream going, so anyone still on YouTube can ask questions. I'm gonna mute my streaming audio. there. Okay. All right. We have audio. Yep.
You ready?
My ugly voice. All right, folks. Those that are listening can actually hear me over the stream. We're back on with our next presenter.
All right. Hi, guys. I'm Alexa Troutman. I'm one of the ER residents. For those of you who don't know me, I'm going to talk about strokes. I gave this lecture last year. Just updated a little bit. So, is it working okay?
Yeah.
Okay, cool. Yeah. So mine is not going to be nearly as long-winded as the last one. And I talk really fast. So just holler if you have any questions. So we're going to start with the 3 different types of strokes. Transient, which is otherwise known as TIAs. We used to go off the definition that this was a time-based issue, whereas if the symptoms would resolve within 24 hours, we would call it a TIA. They're now using a image-based classification. So these are people who have symptoms but then do not have any findings on MRI. So just because the symptoms resolve doesn't mean that they won't have changes on their MRI. And in those cases, they cannot be classified as a TIA any longer. The next type is going to be your bleeds, and there's the 2 main different types of this are going to be your intracranial hemorrhage. These are usually the small arterioles or arteries, and then the injury can expand into a localized hematoma. This is most commonly caused by high blood pressure. You can also see this in trauma patients or people with coagulopathies. This is also common in drug abusers like cocaine and amphetamines. They'll usually have little small intracranial hemorrhages. And then, of course, the subarachnoid hemorrhages are the big concerning bleeds we talk about a lot, and those are most commonly from the rupture of your arterial aneurysms. And then ischemic stroke is basically going to be the main topic of our talk today. There's a couple different types of these. Thrombotic is basically just local disease. So you'll have either large or small vessel disease where there's plaque buildup in the arteries of the brain, and then they'll get decreased blood flow. But basically the difference between this and the embolic is going to be the local disease, whereas embolic is obviously a distal clot that travels and gets lodged in the brain and causes ischemia there. And then systemic hypoperfusion is pretty rare, but we do see it usually more in the hospital or in like significant trauma patients. You'll see people who just don't have good blood flow anywhere will have stroke symptoms, and that's just because their brain's not getting any blood. So lifetime risk for everyone is about 25%. It's obviously more common in older ages, and except in men. The younger strokes we see are usually in men. Women tend to be older, usually over 75. It's also more common in minorities, especially blacks and Hispanics. We are starting to see more strokes in young adults since the 80s, really. And I think even now with all the COVID stuff going on, we're starting to see really just more clot diseases in younger adults anyway. But this will be interesting to see how the research plays out with the new COVID infections. The big risk factors for adults are going to be the same as any sort of vessel disease: high blood pressure, smoking, diabetes, high cholesterol. And then in kids, the one you really worry about are going to be kids with cardiac abnormalities, kids with holes in their hearts, valvular lesions, vascular lesions, and then infection, trauma, again, would cause any of those hypoperfusion states. I have a ton of really bad memes in here, so I'm sorry that you have to put up with them, but Google did not have very many good memes for stroke, so you get stuck with the weekend instead. So presentation of stroke is pretty varied. It mainly depends on what part of the brain is involved. So your anterior strokes or your anterior cerebral artery, these are not very common. They're less than 3%. These are more commonly motor symptoms, and you'll usually see these in the leg more than the extremities more than the trunk. You do usually get sensory loss as well. These can also be the kind of urinary incontinence and the gait ataxia. Usually if they are ataxic, they'll have a broad-based gait, and they're kind of have these short little shuffling steps. The middle cerebral artery is going to be your most common site for occlusions. this is going to cause deficits on the opposite side of the stroke. And usually you'll have some aphasia with this and vision difficulties. And these people, if it's a large vessel occlusion, they can have some neglect. With the middle cerebral, it's going to depend on whether it's the dominant hemisphere or the non-dominant. Again, either way, it's going to be opposite side. But if it's your dominant hemisphere, you'll usually have motor and sensory, and this is going to be more likely to be truncal. So face and arm is going to be more common than the legs. Again, they'll have aphasia, vision difficulties. Non-dominant side is going to be pretty similar, motory and sensor deficit, opposite side, again, truncal. But these people can actually have some more interesting and unique symptoms. They can have the inability to like recognize their body part. They'll have more neglect symptoms, which you usually don't see in the dominant side. And then posterior cerebral artery is about 15% of all strokes. This is obviously your posterior, so it's like your occipital lobe. Most of this is going to be vision. They can have hallucinations, blindness. They can't see. They don't recognize things. Eye movement disorders. They can have motor and sensory. It's not as common. It's going to be opposite side if it's there. And interestingly enough, if this involves the thalamus, they can have what's described as this like intense burning pain. And that's pretty unique for a thalamic stroke. Penetrating vessels or lacunar infarcts are going to be almost entirely motor. They'll usually have hemiparesis. Sometimes they'll have sensory, but it's usually just one or the other. It's usually not motor and sensory. Vertebrobasilar, this kind of depends on where it is. It's going to affect the cranial nerves in this region, so it depends on which cranial nerve's knocked out. They'll usually have some sort of facial droop or vision changes. Vertebrobasilar is that classically taught as 5Ds, dizziness, vision changes, drop attacks, dysarthria, and dysphagia. These patients usually come in nauseous and vomiting. And then the ICA, this is usually presents initially as MCA stroke, but it's kind of just this progressively worsening or stuttering MCA symptoms. They usually don't come in with a full ICA occlusion. So this is kind of the, I'm sure you guys have seen this a million times, what we teach layman people about strokes. I think the B is the newest part of this. FAST was classically taught, but the B, the balance and the eyes, are the newest addition, which is not something that I see most of the population come in for when they're complaining of stroke-like symptoms. Actually, I would say the most common symptom that I see people come in for is numbness, which is not even listed on here. But I thought it was funny because this was another meme I found about the FAST mnemonic. So in managing these patients for you guys, obviously ABCs is going to be most important, reversing any contributing factors, and then determining candidates for TPA or thrombectomy. That kind of will depend on where you go with these people. We'll kind of go into each of these things in depth. So initial assessment. I mean, if you're doing ABCs, airway is going to be important in a lot of these patients because if they come in altered and they're vomiting, you obviously have to worry about airway, or some of these patients will have like bulbar muscle weakness and they won't be able to tolerate their own secretions. In those patients, you also have to worry about airway compromise. And when you're picking up these patients, most of the time they have some sort of speech difficulty or memory difficulty, and it's hard to get good history from them. So asking bystanders is usually very important, and it's really hard for us to get information from these patients when they get to the hospital if EMS was unable to talk to bystanders. So obviously the most important thing is going to be last known well. They've expanded the TPA window up to about 4.5 hours now in some patients. So if anything, if their last known well is within that time frame, getting them to a tertiary facility is going to be more important than standing around and asking additional questions. But like I said, it's hard to get history, so if you can just throw whoever's with them in the truck with you and bring them with you, that's super helpful. The big things are going to be getting IV access to large bore IVs if possible, and then checking a blood sugar is super important in these patients. So the next thing we're going to talk about is reversing any contributing conditions. So there's a lot of things that can mimic stroke. And a lot of this is going to be based off of kind of what you see at the scene and then what bystanders have to say. Alcohol intoxication, obviously, if you've been there multiple times for intoxication calls or the patient smells like alcohol or you pick them up at a bar or something like that. Infections, this is not as common, but if they've been febrile or sick at home, been complaining of neck pain, headache, those people can come in looking like a stroke as well. Drug overdose, again, track marks, pinpoint pupils. Those patients are going to usually just have diffuse decreased alertness and not necessarily focal deficits. Epidural hematomas, this is more common in trauma, so basically just looking for any evidence of trauma, external signs of head trauma, finding out whether they're on blood thinners or they have uncontrolled high blood pressure, if they've been complaining of headaches or vomiting. Hypoglycemia, obviously it's super important to check a blood sugar in these patients. We worry about this more in patients with diabetes who use insulin, especially patients at nursing homes because they are notorious for giving the wrong doses of insulin. And then metabolic disorders, pretty much any electrolyte disturbance can cause some sort of muscle weakness or neurologic deficit. Calcium's the big one, and then of course low sodium can cause things like seizures, decreased levels of awareness. Uremia is also a big one, and then you have to worry, of course, about elevated ammonia and hepatic encephalopathy. But things like thyroid storm and mixed edema coma can also cause stroke mimic symptoms. And those are all going to be more common in patients who have a history of kidney or liver disease and are unable to clear those toxins, or if they've been sick recently, diarrhea, vomiting, and that's caused their electrolytes to get all out of whack. Atypical migraines can cause some weird symptoms that can look like strokes. Usually those patients obviously will have repetitive nature of their symptoms and kind of know what their neurologic deficits are. If it's the first time that they're having neurologic deficits with it, we work them up just like a stroke anyway. Neuropathies, Bell's palsy obviously has both the forehead and lower facial droop. It's not very common, but we get tested on it a lot. And then seizures, again, most patients know that they have some sort of neurologic deficits after their seizures. It's usually not a first time. Tumors can cause all sorts of neurosymptoms, and then of course high blood pressure, hypertensive urgency or emergency can cause stroke symptoms as well. So this is the current guidelines for TPA for ischemic stroke. There's a ton of factors, and I pull this out on my phone literally every time I have a stroke patient. The biggest things that we don't usually have information for when the patient gets there is going to be things like if they've had any recent surgeries or bleeding, if they're on blood thinners, head injuries, if they have cancer, any sort of tumors in the brain. Those are most of the things that, especially if they've never been to our hospital before, we usually don't know the answer to. Most of the rest of the stuff we can pretty much figure out, especially if the patient's able to talk to us and get us history. But those are kind of just important things to think about when you're getting medical history from the patient's families at the scene. Just asking about recent stuff that's been going on, recent illnesses, hospitalization, stuff like that. And then, of course, how they presented is important. Things like having a seizure at the onset is obviously an exclusion criteria. So just asking families what happened when this started is important for us, and it can take us out of the TPA window. And then blood thinner use is a big one. We don't even have to go through all of this exclusion criteria if they're on blood thinners. So, sorry, got carried away there. This is what we use in the hospital, the stroke score. It takes a long time to do, but it's basically just a thorough neuro exam. It's what we have to give the neurologist whenever we call them. We are supposed to grade this on the patient's first response. It's not the best response, so they might, you might ask them what the year is and they don't know, but then they come up with it 2 minutes later. You're not supposed to judge off of that. You're supposed to go off what they initially tell you, and you're not supposed to coach them through it. This is really hard to do a lot of the time because patients' family will try to coach them through it. But really, you can pretty much tell whether it's a high score or a low score just by looking at them. The scores have been shown to correlate with clinical outcomes, so less than 4 is usually a small vessel occlusion, and they have pretty favorable outcomes. They usually have a high likelihood of having functional independence regardless of what you do with those patients. And on the opposite end, patients that have a score greater than 22, that's actually usually a contraindication to TPA just because it's such a large vessel occlusion and there's such a large area of the brain that's been damaged that the risk of hemorrhagic conversion there is so high that it's not good to give them TPA because they will usually have a very, very poor outcome. So the next most important thing, obviously, in taking care of these patients is going to be figuring out where to take them. It's easier here because both of the big hospitals here are stroke centers. But for smaller outlying facilities, big difference is going to be primary stroke centers and comprehensive stroke centers versus outlying smaller facilities that do not have the capability to do stroke care. The comprehensive stroke centers we don't have these here. This is going to be the places like Kansas City. I'm pretty sure Springfield's a comprehensive stroke center. All the places that can do basically all of the things for the stroke patients. We don't do thrombectomies or intra-arterial TPA here, so we don't fall into that category. I found a bunch of clinical stroke scales that EMS use. I'm not sure which one you guys use or if it varies by service, but this was kind of a breakdown of all of them and how they compare to each other. The Cincinnati is pretty easy to do. I mean, it's only 3 variables that you're looking at, and it's most commonly used. It's very good at predicting large vessel occlusions. Those are going to be like your stroke scales of about 16 or 15 or above. But it's only 70% sensitive, so it can miss a lot of things too, which again is the plus side and the downside of using only 3 variables. But it's pretty quick to do, and you can get a good feel of whether this is a large vessel occlusion and something that you need to take to a big stroke center or just an outlying facility. This is the Los Angeles pre-hospital stroke scale. It's not as comprehensive as the last one, but it's quicker to do. The problem is it has all of this screening criteria that takes a while. This one is you just look at them and then have them squeeze your hands. You're looking for their smile, grimace, grip, and arm weakness, so it's really fast to do once you get through all of the screening criteria. So this one is more specific and sensitive for a large vessel occlusion, but again, it has all of this specific screening criteria, and most patients, you can't get a full history on them, so this is not something that you're able to categorize them in or out of. This is the Melbourne Ambulance Stroke Score. This is a newer stroke score, so it's not been as validated as many times. But it has good results so far. They say that scores greater than or equal to 3 is 98% sensitive for a large vessel occlusion, but only 30% specific. If you bump it up to a 4, then it's 81% sensitive, but only 50% specific. So it's super sensitive, which is great for all of these screening criteria, but not terribly specific. But again, these are just screening criteria of thinking of where you would try to transfer these patients. This is the Miami, it's called MEND, and this is kind of what it looks like from the research I did where we're trying to go with all of these pre-hospital stroke screening guidelines. It's very comprehensive. It's just a lot to get through in the back of an ambulance. So it kind of is a combination of the 3 previous. It has some ruling in criteria, and it also has some pretty easy exam findings to do, but like I said, this is a lot more to do than just have them smile and squeeze your arms and hands. So this was kind of a comparison of the three without the mend on there. Like I said, the Los Angeles is pretty quick. It's more sensitive and specific, but it doesn't really help you in severity of the stroke scale. And the inclusion criteria is pretty time consuming. The Cincinnati pre-hospital score is pretty easy, and it's based off the NIH stroke scale. So it's been verified many times, and it's an older screening tool, but it does not evaluate for posterior strokes. So it misses all of those patients, and that's why it's got such a low sensitivity. The Maryland is based off the Cincinnati with new NIH inclusion criteria. This is the one that I talked about that's newer, so it's not been validated as well. And then the MEND isn't on here, but like I said, that's the newest one, and it's kind of a combination of the three, and it is more inclusive, but it's more time consuming. So these are the hospital's core measures that we have to do. I don't know why they call this brain attack. I think that's the most ridiculous thing I've ever seen. But for all of our suspected strokes, this is what is supposed to get done in order for the hospital to meet all of its core measures. Obviously, the biggest thing is going to be that door to thrombolytic 60 minutes time frame. It's really hard to do. So for you guys, this is the TCD task force stroke recommendation for EMS. Basically, the main goal for you guys is to group their patients into immediate life threat versus your patients that are within the therapeutic window of 3 hours, potentially within the therapeutic window of that kind of in between range of 3 to 6 hours, versus the patients who are not within the window, greater than 6 hours of symptom onset. This is a super awesome flow chart to use. But again, it's just breaking it down into patients who are within the window and what time frame and what you do with those. Again, it doesn't really change anything for you guys here because both the hospitals here are able to take care of stroke patients, and you're not going to be able to get them to a comprehensive stroke center within a reasonable amount of time. So this is more for the outlying smaller EMS crews again. But these were their recommendations. Obviously, again, ABCs are going to be the big thing with these patients. Just like with the new heart attack guidelines, they're not recommending supplemental oxygen unless their SpO2 is less than 94%. This is, again, thought to be because of those increased free radicals, and ischemia is causing more damage now than we think that supplemental oxygen is providing benefit. So they don't recommend it unless patient is hypoxic. Again, you have to worry about their airway for the decreased level of consciousness or the vomiting patients. Checking in blood sugar is super important in these patients. If it's just a hypoglycemic episode, it'll usually resolve just with some oral dextrose. Save everyone a lot of time in imaging. Vital signs, EKG. Sometimes you can get information like if the patient has AFib, things like that, or ischemia. That can cause all sorts of goofy symptoms in patients. And then, of course, getting a last known well sign. This, the TCD guidelines had recommend using the Cincinnati pre-hospital stroke score. I don't even think that we care what EMS calls in with. Usually we just go based off of their gestalt anyway. But obviously the big thing is going to be moving these patients. They recommend, again, getting big IV access, treating hypoglycemia, doing a thorough stroke exam if you have time. They recommend contacting the hospital, obviously trying to give them a little bit of a heads up. We usually will try and get our clinical pharmacist down there to the CT if we have enough of a heads up. And then they recommend calling back and updating if the condition deteriorates or if their blood pressure changes. We really care about blood pressure in these patients, so we're trying to keep it below 180 over 105. Or if they go super hypotensive, we worry about that too, again, with the systemic hypoperfusion. They recommend keeping the head elevated no more than 20 degrees, trying to keep them flat, keep the blood flow to their brain. And then, like I said, about 10 minutes prior to arrival is awesome. If you can give us more heads up, that's great. That way we can kind of get everything ready and try and meet you guys in CT. I'm almost done, I promise. So obviously the big thing is going to be time with these patients. Like I said, they've kind of expanded the stroke window out to 4.5 hours now on most patients. Less than 3, almost everyone's going to be included in that. So we kind of go based off of that, of what we even do with these people. Obviously, most of the time we meet these people right in CT, try and get them there before they go to a room. And if we have obvious deficits, we'll try and eyeball them as you guys roll in the door. And if it's pretty obvious that's a stroke, we'll call and have the TPA mixed up right then. Like I said, we've got a new clinical pharmacist down in the ER, which is awesome. They can mix the TPA at bedside, and they usually will have it down in the ER if we have enough heads up, and they'll start to mix it whenever we give them the okay, which has really helped with our times. And then usually from there, we'll talk to the neurologist and see what kind of imaging they want. It's usually a CTA of the head and the neck to look for clot. Sometimes if it's a large enough vessel occlusion, they'll just want to do a perfusion scan and look for the penumbra and those type of patients that we're considering transferring out for thrombectomy. But that is kind of at the discretion of the neurologist. This is our flow sheet of how we manage things at Freeman. Our stroke coordinator came up with this, and it's super thorough. It's actually a really good breakdown of just kind of how we do it. Again, one of the first few things we do is check a blood sugar and a creatinine and get an IV. We always have lab there for code strokes, and they get just those basic blood works. Once we get the CT report back, we're looking obviously to decide whether it's a bleed or an ischemic stroke. If it's a bleed, we're going to call neurosurgery, and it's pretty much done from there. But after that, if the CT looks fine, we're looking for those large vessel occlusion deficits, gaze, deviation, vision changes, aphasia, neglect, paralysis, anything like that makes us think it's a large vessel occlusion. And we go ahead and plan for TPA if they're still within the window or they meet criteria. Our core measure for that is 60 minutes. The TPA needs to be started. And then once we started on those patients, we call the neurologist. Most of the time we'll start it without calling the neurologist, but it just depends on the provider. So if you have patients who obviously don't meet the TPA criteria, their last known well was a long time ago, or they woke up with it, then we kind of go down that separate branch. Most of those patients we end up not doing much with and just admitting them for a stroke workup. But like I said, those large vessel occlusions will start TPA and usually take them over to get that perfusion or the CTA and see if they are going to be candidates for thrombotic therapy. And most of the time, those patients will transfer out to Kansas City, sometimes Springfield, but most of the time Kansas City. The big things we worry about are going to be blood pressure control and reversing anticoagulants. So most patients who are on anticoagulants, you obviously can't use TPA. That's a contraindication, but those patients can still receive a thrombectomy. So we'll usually try to give them something to reverse whatever they're on and then transfer them out with that running so they can go and get their clot taken out somewhere else. Again, these are kind of the 3 things I've talked about briefly. TPA is the clot buster drug. We've got 60 minutes door to needle time. In patients who we give TPA, we always have this conversation with them or their family about the risks associated with it. TPA has a 2 to 6% chance of intracranial hemorrhage after you give it, and then about 50% of those who get bleed after TPA, it will be fatal. And there was a landmark study that was done fairly recently that actually showed about a third of the patients that got TPA would have recovered without any disability at 3 months if they hadn't gotten the TPA. And about half of the patients who get TPA would only have recovered if they got TPA, but this was the study that confirmed that 6% bleed. And again, 50% of those are fatal. So, there's been some neurologists who will push TPA in kind of smaller vessel occlusions, and it always makes me super nervous. That's a huge risk to these patients who only have very minor deficits that they could basically be a vegetable for the rest of their life or have a really bad bleed and just die that day. So it's something we talk about. at length with these patients. The next option is going to be your intra-arterial thrombolysis. We have to decide whether we're transferring these patients within 90 minutes. They need to be out the door and on their way. Intra-arterial thrombolysis, again, is not something we do here. It's basically just clot-directed TPA. They go up through your ICA and can find the area that is ischemic and just give the little TPA through the artery. It obviously is less risk than just the IV TPA because it's not as systemic, but there's no controlling where the TPA goes after you give it in the artery, so it still does have systemic symptoms and can cause bleeds. These patients usually have a lot of strict criteria, which we don't even screen for. We just kind of transfer them up there and let them handle that. And the mechanical thrombectomy is just going in to retrieve the clot. These patients have a longer window. They can be up to 8 hours from symptom onset. And the criteria for this is a little less strict than the intra-arterial thrombolysis. So this is probably more of a feasible option for most of our older patients who are on some sort of medicine, because like intra-arterial thrombolysis is not an option if they're on Eliquis or Coumadin or anything like that. So once we admit them, if we had a patient who came in with stroke symptoms and they'd been ongoing for more than 24 hours, or we don't really know when they started, we will just admit them and do a stroke workup. Usually those patients will all get an MRI. Again, this is kind of trying to rule out that transient effect. We're looking for damage on the MRI to say that they actually had a stroke. We'll usually do some sort of imaging of the neck to look at the carotid vessels and make sure that they don't have any plaque buildup there. All of these patients go on telemetry. You're looking for AFib or any sort of other dysrhythmias that may have caused the stroke, as well as get an echocardiogram with a bubble study. You're looking for septal defects that cause blood to flow in the opposite direction, or some sort of vegetation, which is not very common. And then obviously just basic blood work. You're looking for coagulopathies or clotting factor disorders, things like that. And then long-term management, all of these patients get sent home on some sort of blood pressure control medicine as well as cholesterol medicine. Most of these patients will require some sort of physical therapy or occupational therapy, just depending on the severity of their deficits. And then the last thing I have is going to be just some pearls from our stroke coordinator. She is super awesome. I don't know if you've ever met Sherilyn, but she does a lot of lectures like this, and she just had some things she wanted me to talk about, and I think we've talked about most of them at length. She was super adamant about talking about the last known well time. Again, obviously it's super important in determining kind of where we go with these patients. She again talked about making sure that you guys ask witnesses questions if you have the ability to, especially about how symptoms started and when they started. She recommended trying to bring them with you to the ER if you can. And then events at onset, again, the seizure, trauma, things like that. Their medical history, are they a diabetic? Did they take too much insulin? Are they an alcoholic? Things like that. Do they have a history of cancer, of clotting disorder, of bleeding? All of that can help with us with our management once they get to the hospital. Checking a blood sugar again. I don't know how many times I can say that. The rest of that. Oh, she really wanted me to mention making sure that we get a weight before they go to the scanner. Apparently this was an issue, but I don't think it has been recently. I think that's old news for her, but she really wanted me to stress that to you guys. And then she said, when in doubt, call it in. She loves, false activations. She says she would rather come in and not have it be anything than miss one and not be there. And, we'd all get in trouble for missing a stroke, and it causes significant damage to the patient, obviously. So, yeah, that's basically all I have for you guys. Like I said, short, quick, to the point. If you have any questions, I'm here. Otherwise, I'll let you guys hopefully go to lunch a little early.
Thank you.
Thank you.
All right, we're going to break for lunch. Before we do you guys have any questions for Dr. Troutman?
Sales courses, yeah. Is this still on? Yeah, I thought the Mend is all the research I was doing was showing that Mend was going to be the newest one that was coming out because the data on it is so good, which makes sense. I mean, it's a combination of all the old 3 that everyone's been using, so we've got years and years of studies on it.
Lots of thank yous.
Thank you guys. Enjoy your lunch.
All right, folks. It is. I lost my. The world time is 12:08. So take a little over an hour. We'll start back at 1:30. How's that sound? We're gonna go ahead and end the stream, and we'll sign back on. I'll send out a message probably when we're getting ready to stream live again, so you'll kind of be able to get ready before we actually start. Otherwise, we'll